Hello ladies and gents, the cervical spine. So just to remind ourselves, we've got the cervical spine, the neck, the thoracic spine, and then the lumbar spine. Then we've got the sacrum and the coccyx that follow. The cervical spine has got 7 vertebrae, C1 to C7, C referring to cervical, 1 to 7 the number referring to the number, the vertebral number itself. There are actually 8 spinal nerves, C1 to C8. The reason being, from C7 to T1, between them two vertebrae is where T1 exits, hence 8 spinal nerves. When we look at the spine from a lateral view, so you're looking at the patient side on, this is anterior in the given situation. Here's our cervical spine, and it sits in a curvature anteriorly. So that's what we call the normal cervical lordosis. Just above the cervical spine, we've got the occiput. This is the bone just at the back of the head. There's the foramen magnum, the hole in there, through which is where the spinal cord travels, as well as a rather important structure, the vertebral artery. Hold the thought on vertebral artery. The actual cervical spine, C1 and C2, these are atypical vertebrae, meaning that the vertebral landmarks, the bony landmarks, are not typical of the usual vertebra. C1 is called the atlas because the head, the Greeks used to believe the head being the most superior part, the atlas resides on top of C1, the atlas. C2 is known as the axis, as in an axial, because it promotes, or otherwise it is responsible rather, for axial movement, i.e. rotation with the neck. Admittedly, the main function with the neck is rotation. So 45 degrees of rotation in this direction, 45 in that direction, comes purely from the AA joint, the atlantoaxial joint, the joint C1 to C2. The remainder 45% on either side, i.e. in total 90 degrees, comes from the rest of the cervical spine. The occipito-atlanto joint, the OA joint, i.e. the joint between the occiput and C1, is actually a saddle joint, such that the occiput is a concavity, convexity, and C1, the receiving, is a concavity, so it actually sits in like so saddle, and as a result it promotes, or otherwise is responsible for, the nodding movement, so extension and flexion, albeit very local. The vertebral artery I mentioned a moment ago, this red structure here, if it's visible or not through here, that is a vertebral artery, or represented here, runs from the C1 to C6, or let's say go to the waist C6 up to C1. It ascends superiorly, and it actually runs through little holes inside the vertebrae, and when it exits C1 it then goes backwards, sideways, and then enters the foramen magnum. Why is this an important structure? Because when we do motions in the neck which are turning the head, side bend and extension, so knocking it back, that can potentially compromise or occlude the artery in a condition called VBI, vertebral basilar insufficiency. The importance with this otherwise is that each vertebral artery supplies 20% of the brain blood. So in total 40% of the brain's blood supply is supplied by the vertebral arteries. The remaining 60% comes from the internal carotid arteries, 30% each. From a clinical viewpoint, so we look at the cervical lordosis, this curve. The apex of the curve is around the C5 level. As a result, osteoarthritic change occurs primarily and initially at the C5-6 level. After that, as it progresses, it affects the C6-7, and then it goes inferiorly, and then it actually goes superiorly on the other side of the apex to C4-5. So in order of occurrence, it's a C5-6, C6-7, and then C4-5 for osteoarthritic change, typical manifestations or symptomology is such that the patient will complain of a constant ache, usually stiffness, associated with stiffness. Morning stiffness lasts for 30 minutes or thereabouts, really reduced with movement, or otherwise occurs due to prolonged periods of stationary, so remaining stationary for prolonged periods of time. So when we run our hand down the back over here, we can actually feel the SB, the superior and the spinous processes. The way to locate C7 or C6 is to actually run your finger down and you feel a prominent vertebra. That's called the vertebral prominence. You then ask the patient to look down to the floor, i.e. C-spine flexion, and you'll go superiorly, and that's C6. How do you know it's C6? Well, when you then ask the patient to look up to the ceiling from that position, that palpable SB for C6 should no longer be palpable. So that's how you know that's C6, and below it C7. C7 is an important one again, because the transverse processes, so these extensions on the side, so the SBs are the ones that protrude backwards, the ones that we run as fingers down when we run our hand down someone's back. But the TPs, with C7, what can sometimes happen is that you can have an extension of the TP, the transverse process, so much so that it resembles a rib. That's known as a cervical rib. So cervical rib is not a true rib, rather it's an extension of the transverse process of C7. This can lead to conditions that imitate thoracic outlet syndrome. So what's thoracic outlet syndrome? The resolution, by the way, for cervical rib, if it's problematic, is a surgical excision. Thoracic outlet syndrome, so we've got the brachial plexus, the network of nerves that supply our arms, one on each side, comes out from C5 to T1, and it runs underneath the collarbone but over the first rib, so between these two structures, and then it travels down the arm. Now, if you want a recollection as to the myotones and the dermatones, just refer to my video on upper motor neuron examination. Beg your pardon, upper limb examination, neurological examination of the upper limbs. The brachial plexus you can then assess for. From there you can also have the most common nerve that can be trapped is the C6-7, the radial nerve. That will be treated over here. The other nerve that then otherwise is commonly trapped in the upper extremity on the arm is the median nerve, causing carpal tunnel syndrome. And aside from that, headaches is the last thing I want to mention. Headaches can be due to malfunction or dysfunction in the cervical vertebrae. Namely, it's a C2 level. C2 level is known as headache level, so dysfunction or malalignment between C2 and 3 can cause headaches, or otherwise the actual musculature at the back of the neck, just at the base of the occiput, so just below the occiput, the suboccipital muscles, tightness or hypertonicity there can cause headaches also, and that's usually seen in stress. I hope that helps. Thank you for watching. If there's anything I missed or you'd like for me to speak about any particular condition, don't hesitate, send me a DM and I can always do something to that effect.